Hello, my name is Swathi Kiran. I'm a professor at Boston University. I run the Aphasia Research Laboratory at Boston University, and I am also the research director for the Aphasia Resource Center. As you can tell, my area of research is in aphasia and aphasia rehabilitation. Today, I'm going to talk about technology-based options, treatment options for individuals with aphasia. Before I start that, I have a few things to disclose. I am an employee of Boston University, and I'm also the co-founder and scientific advisor of Constant Therapy, and I will be talking about Constant Therapy today. I have received financial compensation from ASHA for this presentation, and most of my work is grant funded from the NIH. I have no non-financial disclosures to make. All right. Let's start with what we know about the recent advances in innovations in telecommunications that have changed the way we do rehabilitation for individuals with aphasia. There are several different models here. There's the teleconsultation, there's the telehome care, there's telemonitoring, as well as teletherapy. And as you can see, teletherapy is a big area for us in aphasia. Teleconsultation is when healthcare professionals provide patients in remote locations with healthcare services, including evaluation, diagnosis, and treatment. Telehome care includes the addition of an interaction with the doctor and nurse in this previous scenario. Telemonitoring is remotely monitoring patients who are not at the same location as the healthcare provider. And now patients have monitoring devices at home. Now this could be something that collects heart rate or blood pressure, and the results of this devices are sent to their healthcare providers who then monitor and alter the care services. Teletherapy is the delivery of speech-language pathology and audiology services, as well as other kinds of therapy services at a distance by linking the clinician to a client or a patient for the purpose of assessment, intervention, and/or consultation. And this is really a field that has taken off quite a bit over the last few years. And there's quite a few studies that have examined the efficacy of rehabilitation techniques, such as video conferencing, for individuals with hearing problems, stuttering problems, as well as motor issues. Aphasia therapy has been delivered over the internet for individual patients and has proven to be as successful as one-on-one in-clinic therapy sessions. And I will also talk about computerized brain training software that have been designed to help normal adults that are also being applied for individuals with aphasia. So let's start first with tele rehabilitation. So these are really therapy options for people who cannot travel to the hospital or rehabilitation center to receive services, and being able to access therapy at home through their computer is a huge practical advantage relative to trying to reach a hospital or a rehabilitation center. Speech and language therapy services are actually well suited for these kinds of tele-rehabilitation services due to the emphasis on auditory visual interaction. So it's actually easy to do this over phone, video conference, or internet-based service. There's few studies, as I mentioned, that have shown this therapy delivery service to be as effective. And there are several universities, such as the City University in London and New York, the City University in London and the University of North Carolina in Greensboro, that essentially have these sort of therapy services for patients to avail of. And so Skype has been used as a mode of therapy for individuals with aphasia. Meera Goral has published work where she's shown the patient initially receives one-on-one therapy and then receives Skype therapy from a distance, and the therapy is found to be effective. Most importantly, Mieke van de Sant Konderman has written in a review paper that with the advent of these innovations in technology, it sort of changes the dynamic of the clinician and her role. So now the clinician is not just somebody who remotely delivers the therapy. She becomes an orchestrator or facilitator of therapy services, because there's so much more that can be done in this context. In addition to just delivering therapy over the internet, there have been a few studies that have looked at virtual therapists or avatars. For instance, Thompson et al. Have developed the syntactics virtual therapist, where an avatar or sort of a virtual speech therapist provides speech production therapy called syntactics through a computer, and this avatar delivers feedback as and when needed and moves to the next trials and items as and when needed. A very similar virtual therapist is developed by Leora Cherney, and it's called the Orla virtual therapist. And as in this case, as in the previous case, this virtual therapist provides cues to the patient when he or she is reading sentences in therapy and provides as much reinforcement and feedback as needed. In addition to virtual therapists and tele rehabilitation using video conferencing, there's quite a few computerized brain training software programs that have been developed really for normal adults, but these programs have also been applied to individuals with aphasia and brain injury. So I'll read a couple of these to you. CogMed, for example, is targeted at improving working memory abilities in individuals with brain injury, and studies have found improvements in working memory skills in individuals with mild deficits. Posit Science, which is another software, has also been examined in the context of a clinical population. For example, Barnes et al. Examined the effectiveness of the software in improving auditory processing speed in individuals with mild cognitive impairment. And what they found, differences between the experimental and control group were not statistically significant. Verbal learning and memory measures were higher in the experimental group than in the control group. Lumosity, which I think most people have heard of, has also been implemented in the context of individuals with mild cognitive injury. For example, Finn and McDonald have used the software to target attention, processing speed, and visual memory in experimental and wait-listed controls. And they showed experimental participants improved on the training exercises more than the control individuals. There's a whole host of other software programs that function more like AAC devices, like text-to-speech devices, and I'm not going to have time to go over them today. However, the bottom line is there's an increased awareness and momentum for applying computer technology in the rehabilitation of aphasia individuals. In addition to these sort of more broad software programs, there have been software programs that have been specifically designed to work with patients with aphasia. For example, De Borg and Van de Sand-Konderman have developed the multi-cue software program, which provides varying levels of cues to the patients. And Fink et al. Have developed Moss-Talk, which is quite similar, where it provides cues to patients when they have trouble coming up with the names of things. There are other computerized methods that have been published that are sort of in-house software programs. And I will be talking about Constant Therapy, which is sort of a broader software platform. All of these studies provide promising preliminary results for the use of technology in rehabilitation of patients with brain injury and aphasia. The problem with many of these studies, though, is that they're based on very small samples. So we sort of know what therapies work for individuals, but they're all based on few patients. And so we really don't understand which treatments work for which patients at a much grander level. And because of that, we're not yet at a position to standardize and personalize the intervention for each individual patients. So I'm going to talk about a study that we published earlier this year where we tried to do that. We try to standardize the therapy and provide personalized intervention for individuals with aphasia using an iPad-based software technology. So in this study, there were 51 patients, as you can see on the screen, and they were really quite heterogeneous in their language and cognitive profile. So on the x-axis, you can see the WOB scores, and on the y-axis, you can see the CLQT composite scores. And there's quite a bit of spread here. And the experimental patients, of which there were 42, came into the clinic once a week and worked on the software platform Constant Therapy with the clinicians, but then took the iPad home and were asked to practice as much as possible at home. The control patients came into the clinic once a week with the clinic and worked with the clinician, but did not take the iPad home and were not practicing any of the software at home. All the patients received pre-treatment assessments as well as post-treatment assessments before and after this intervention program that lasted 10 weeks for these patients. So the procedure here was really, as I said, trying to standardize the therapy that everybody gets, but individualized in a way that each patient only gets the therapy that's based on their impairment profile. So the first step was to assess the performance of the patient. And to do this, the clinician would go through this array of tasks and assign a series of baseline tasks. And based on the patient's initial performance, as long as the performance was less than 90% accuracy, she would assign that task as a treatment task for the patient. So for the more severe patients, she could work on things like rhyming tasks, where now you have to look at this picture and see if it rhymes with the word lake, and you have to be able to do that. You have to retrieve the word form and answer the question. Or you look at the clock and you try to figure out how many minutes are there until 12:45. Again, you have to retrieve basic math skills. For the higher level patient, there was a functional math task, for example, where they had to calculate tip or navigate their way through a map. So there was various of tasks here, and the clinician would have to decide which was the best task to assign that patient. Once that was done, the patient would then get a series of tasks that were assigned to his treatment program. And this was essentially individualized based on what level of performance he was ready and willing to do. So the clinician would assign a series of tasks, as you can see on the left figure, in terms of that person's treatment program, but then give this person as many items and at specific levels of difficulty for that individual patient. So she could assign 5 items for task 1 and 15 items for task 2, because she knew that he could work on the second task much more easily. Once that was done, the patient would practice with the clinician during the weekly clinical sessions, and the experimental patients would take the iPad home and practice the program as often as possible. So in this study, we asked the patients to practice up to 6 days, but there was no time limit or prescription of how much they needed to practice. So for them, once they reached home, it was easy for them to log into the account and press start, and the program would go through the specific homework program that the clinician had assigned for that patient. So every patient had his own homework program. And here are some examples of how the task looked. And here's a clinician working with the patient during the session, where the conversation was more about how did the session go, were the therapy tasks easier for you or harder to do, and she would watch the patient as things went along. So I'm going to show you a video of how this works.
Good job.
Chickadee.
Please spell out the word that you hear.
So here's an example of a task that the patient would do. This is the word spelling task, and she has to hear the word that's being presented and use the tiles to spell the word. So you can see how she's solving the task.
No.
So when she makes a mistake, it corrects her.
Whoa.
Good job.
Eggplant.
Love it.
I liked how you figured it out. You were like, pull. You figured out that, then you were like, and. Good. Good job.
I have to do that on my spelling
Yep.
list.
Stop.
But it works. It
So in that example, you can see that the clinician is having a very different conversation with the patient, where she's telling the strategies that the patient used worked for her. Here's a different example where the patient's doing an addition problem.
Please solve the
I should
problem
take
below.
all going on again. I know I should do these too. Okay. So we're gonna do it again. Had that before. And this one you say do a little new. Okay, so thinking that. So this would be 5. Is that me? I don't. So, we are gonna working so hard. All right, let me think about
Yep.
this.
So what you see here is we're able to now not just see whether the patient's getting it right or wrong, but how they're getting it right. You see when they're making the right kinds of additions and when they're
It
making
doesn't
mistakes and
like
why
it.
they're making the
So
mistakes.
it's
So you can see how she's correcting herself now.
And if I get it wrong, let's face it, I'm doing this the first time. All right, don't get mad at me now. Here
I
we
won't.
go. How we do? 1, 2, 3. Ah!
Good job.
Oh, wow.
That was
All right, and that instant feedback helps them learn. This is a different task. This is a syllable judgment task.
Lemon.
Woman.
Lemon.
Woman.
Does this word
So she has to decide whether it has 2 syllables.
Wheelchair.
Well, yeah.
Wheelchair. Does this word have 2 syllables? Subway.
What way?
Does this word have
Again, the emphasis here is not just getting the right answer, but how you get the right answer. What is the mechanism or strategy that you're using to get the right answer?
cat?
Rat. Rat.
Does this word have 2 syllables? Motorcycle.
Okay, so here are examples of how these therapies were done. The clinician was always there watching the patient, giving the right feedback and providing input about what was working and what was not. And in addition to providing that level of feedback, the clinician could watch the patient's performance every day remotely as well as in the session, and was able to then decide whether the patient was ready to move to the next level or the next task and so forth. So to make those types of clinical decisions, she had available to her a snapshot of how the patient was performing over time. So what you see in the first box is these little green boxes that tell her that the patient is above average in terms of the performance. In the little orange and yellow bars, you see that the patient scores are lower and the patient is below average relative to everybody else who has done that task. So sometimes she might decide to keep the patient on the same task for a little bit longer because they're still lower than what the average population is doing on that task. She could also click on any one of those buttons and see how the patient performed across time on that specific task, and that's what you see in the second figure. And she could look at this in terms of latency as well as accuracy. And she could also click on any one of those bars and then get detailed information about what items were presented in that specific session. So that's what you see in the third figure. And here she can see items that the patient got right, which is in green, and items that she got wrong, which is in orange. And she could then look at exactly what items were presented and what the patient was having trouble with. So the treatment was very much geared towards what the patient was able to do and not able to do. So back to the study. Once all this data was collected, the patients and the experimental patients and the control patients received an average of 12 weeks of treatment with all the missed sessions and so forth. So they didn't differ on that. But the frequency at which the experimental patients practiced the software was quite different from that of the controls. So as you can see on the left, there are patients who are coming in once a week and working with the clinicians. And you can see that there's a timestamp once a week, whereas the experimental patients are practicing it during the sessions as well as at home. And every one of those boxes shows that they practiced it at home, and sometimes they would practice it multiple times at home, and that's the shading of that particular box. So the dark blue boxes indicate that patient logged in and practiced more than once. So that allowed us to look at therapy compliance. And what we found was that if we just compared the experimental patients and the control patients in terms of how much time they receive therapy in the clinic, which is a typical therapy session is about 60 minutes a week, both the experimental patients and control patients got an average of 40 minutes in therapy in the clinic. But when we looked at that additional time that patients were practicing at home, the ideal time would be 6 hours. That is, they practice this every day of the week that they're not in the clinic. And what we found was that patients were practicing 4 hours and 8 minutes on average, more than what they would normally get in the therapy session, which is only 60 minutes. And obviously, all this extra practice does relate to improved outcomes. So this is a busy figure that was published in the paper. But what we tried to do here was to see whether there was overall gains in terms of treatment for each of these 50 different therapy tasks that we had tried out. But we also tried to see whether the individual performance or starting severity was a factor in how much patients improved. So what you look at in this graph is light blue represent participants who show a low score, so lower than average of the WOB-AQ and CLQT composite score. And they're the folks who show more improvement on the tasks marked in light blue. And what you see in dark blue are patients who have higher than average WOB-AQ and CLQT score, and they're showing more improvements on the tasks that are marked in dark blue. What is this telling us? This is telling us that more severely language impaired patients benefit from the simpler tasks because that's what's appropriate for them. And the less severely impaired patients benefit from the more difficult tasks. So remember I showed you the rhyme judgment task versus the map reading task. The most severe patients are able to do the rhyme judgment tasks and they benefit from that. They don't necessarily benefit from a map reading task. But the less severe impaired patients benefit from these higher level tasks. And what we found was low CLQT composite scores, patients benefit from tasks requiring lots of short-term memory practice, whereas the higher cognitive intact patients benefit from tasks that require a combination of language and cognitive skills. So they're really integrating what they know in terms of language and cognitive skills. In addition to performance within, for the tasks that were specifically targeted towards them, we also found that experimental patients improved more on the standardized language tests, such as the WOB and the CLQT, than the control patients on these measures. And what was really interesting was that patients that had lower initial scores on the WOB and the CLQT showed more improvements than did patients with higher initial scores. What does that mean? It means that patients who are more severe have more to gain on these standardized scores relative to patients who are less severe. And this says a lot about implications for rehabilitation for patients with aphasia, because we tend to write off the more severe patients as being the ones with poor prognosis and the ones who probably will not improve as a function of rehabilitation. But this data speaks otherwise. In fact, this data shows that the more severe patients have more to gain from therapy, and we should be continuing to work with them. The study that I talked about had 51 patients, which I think is a sort of larger data set relative to what's been published in this field. But these single case studies and the study that I just mentioned tell us about what's working and why it's working. So they help us understand which treatments work and why they work. But all this really still pales in comparison to the data set that we're collecting when patients can download the software and use this more easily now. So that's the study I talked about, and here's the data that we're collecting as part of this platform. And I would say the average number of patients in the platform is about 400 per task. And what that leads us to is a huge population-based analysis of treatment gains. So we're not just talking about one treatment with 5 patients and another treatment with 3 patients. We now have 51 treatments with an average of 400 patients in each one of these treatments. And now we can start to understand which treatments work and which treatments don't work. So what you see here is a bubble plot where on the x-axis you see latency gain, and on the y-axis you see accuracy gain. And you can see right away it's a pretty busy chart, but what it's telling us in each of these bubbles is the size tells us the number of patients who've actually done the task, and the numbers here are telling us how much gains to expect. So for example, if you take one of these tasks, which is the auditory command task, 402 patients have done this task, and the average gain you see in accuracy is 16 points. The average gain in latency you see is about 31 points. And this really gets us to the point where we can now use this data to then understand which treatments work for which individual patients. Remember, I said at the beginning of this talk that this is something that we don't know the answer to, but now we can break it down into individual patients. So let's say we have a patient who has a stroke in the left hemisphere and has trouble with reading, comprehension, and writing. And so we get this initial language profile. And we now understand that his performance is 45% on comprehension of auditory commands. We can now use this information to say somebody at his level, his age, and his severity should improve to about 23 points. How do we know that? Because in an average data set of 200 people who look very similar to him, that's the average gains to expect. So we're now in a situation where we can use this data to understand how much improvement to expect for a patient and predict how much improvement this patient will make based on this sort of population-based analysis. Here's the same patient who now has trouble also with rhyme judgment task, and so this is a different task. And we can stratify the data we have in terms of the demographics, such as how old the patient is, what's his specific accuracy on the task. And in this particular case, we know from 90 patients that the average accuracy is about 28 points. So we are now at a position where we can slowly start to stratify the data we have about what works and what does not work in terms of improving the treatments that we're working on for these patients and making the best decisions. Here's another paper that came out recently where because we're able to collect data continuously, we're also able to detect sudden changes in behavioral and cognitive performance. So here's a patient who was using the software as part of the study, and at the completion of the study was continuing to use the software. So his first stroke was in 2012, and we saw him for several months after that as part of the study. But then he had a second stroke in May 1st of 2013. And what's really important, as you can see in these graphs, is that there was a decline in this patient's performance that preceded the actual diagnosis. So every one of the tasks that he was assigned, accuracy decreased and latency increased. And this was the first sign that something was wrong. And by the time he went to the neurologist, there was a confirmation of a second stroke. So this continuous monitoring of data allows us to understand more about what's going on in these patients over time. So to summarize, there's a tremendous amount of technological innovations today that provide us with several new opportunities to enhance the rehabilitation we already provide. We now have these tools at our fingertips to make better clinical decisions. And what we are able to do now is to use the data from this population to use the analytics to track patients, to measure their progress, inform the best strategy, and most importantly, predict the best results for these patients. Importantly, we're now able to use demographic and diagnostic information that's sort of the marker to then tell us what's the best therapy to provide which patient and then predict the outcomes. I'm going to stop there. I hope you enjoyed this presentation.